and gram-negative diplobacilli like Moraxella. There is a lot of difference between microbial keratitis and contact lens-induced peripheral ulcers, especially here that you can see the CLPUs are small, they don't have an overlying epithelial defect, and the edema is localized to the area of the infiltrate and spontaneous resolution after removing the contact lens. Decreased corneal sensation, corneal decompensation, epithelial defect, prolonged use of corticosteroids, topical anesthetic abuse, and chronic use of broad-spectrum antibiotics are also risk factors for microbial keratitis. Diabetes, AIDS, SJS, burns, comatose patients, and also those with connective tissue disorders, and Moraxella with alcoholics and debilitated patients. Eyelid diseases like blepharitis and also dacryocystitis, ectropion, entropion, and lag ophthalmos can be risk factors. A detailed history is important. External examination, appearance of the patient's skin condition, facial examination, eyelid, slit closure, NLD, and corneal sensation must be assessed prior to installation of topical anesthesia. Eyelids, lacrimal sac to rule out dacryocystitis, looking at the conjunctiva for discharge, associated conjunctivitis, circumciliary congestion, type of discharge, mucopurulent and bacterial, greenish in Pseudomonas, precorneal tear film. The tear film will have numerous debris. And also you can look at the differentiation between conjunctival and ciliary congestion. The size, shape, location, depth of the corneal ulcer should be examined. The location should be marked schematically. It may be central, paracentral. Central ulcers will lead to poor vision, especially in Staphylococcus and Pseudomonas. Paracentral, like Staph, Pseudomonas, and Fusarium keratitis. Mycobacterium may typically cause peripheral ulcers. Ring-shaped ulcers may be seen in Acanthamoeba, Staphylococcus, Pseudomonas, and fungal. Oval ulcers are seen in neurotrophic. The margins are also important. Healing ulcers have well-defined slopy margins. Active ulcers have ragged margins. Well-defined ulcers could be a healing infectious ulcer, punched out in a neurotrophic, indistinct in a progressive ulcer, overhanging in Murren's ulcer, hyphate and feathery margins in fungal ulcer. Viral keratitis, we are not really, we are only concentrating more on bacterial keratitis. Viral is mostly a clinical diagnosis. Here you can see a dendritic ulcer. Here you can see a disciform ulcer. Here also you can see corneal edema. These cannot be mistaken for anything else other than viral keratitis. Neurotrophic ulcer, you can see where, oval shape of the ulcer, heaped up margins, and decreased sensations. The size of the ulcer is also important for follow-up and monitoring progress. Epithelial defect and size of infiltration should be measured in two largest meridians. In case of corneal abscess, the epithelium may be intact over the infiltration. Rose Bengal or fluorescent staining can be used when necessary. Area of epithelial edema. Infiltration may be single or multiple. Corneal sensations have also to be measured. Base depth and pigmentation should be noted. Superficial and deep vascularization should also be noted. The grading of the ulcer is mild, moderate, and severe, less than 2 mm, 2 to 5 mm, and more than 5 mm. And depth of the ulcer is more than 50% in severe ulcers. And dense infiltrate is also seen in severe ulcers. Scleral involvement may also be seen. The anterior chamber reaction should be seen. Mobile hypopyon is seen in bacterial keratitis. Synecea, rubeosis iridis, iridocorneal plug can also be noted. Pupil and lens size and reaction, and lens of visible for cataractous changes. Scleral involvement warrants the use of IV antibiotics. Posterior segment of visible or ultrasound B scan has to be done. IOP in case of desmetocele, never assessed digitally. Lacrimal apparatus, and systemically the fasting and post-lunch blood sugar. Documentation, slit lamp photography has to be done meticulously. And here you can see the various kinds of documentation, and you can see that as the infiltrate heals, you can see the grayish area as the healing infiltrate. Clinico-microbiological correlation. Pseudomonas ulcers are seen in contact lens users and hospitalized patients with a marked mucopurulent exudate. Pigment fluoresces under UV light. Ring infiltrate, dense hypopyon. Suppuration can lead to perforation. Dense yellow, gray or gray white infiltrate with overlying epithelial defect, mucopurulent exudate, multiple infiltrates, and especially when it's polymicrobial or there is foreign body or in a contact lens user. This was one patient who had Pseudomonas keratitis, and here you can see the infiltrate and a mobile hypopion. So on healing, you can see that she's scarred, so you have to document. This is another case of Pseudomonas keratitis with corneal melt. Streptococcus pneumonia is a focal infiltrate, serpiginous edge, may move rapidly. There could be stromal edema, DM folds, may have endothelial plaque, severe iritis. And here there is one in the graft host junction and another when there is a suture infiltrate. Staphylococcus aureus, well-defined, white gray, creamy. There could be PED. It may be due to prolonged use of steroids, multiple opacities, may enlarge circumferentially, may form an abscess. So here you can see staphylococcal infiltrates. Acanthamoeba keratitis, this is courtesy Dr. Paras. This is a ring infiltrate, appears in a pretty late stage. It could be a plaque-like presentation. It could be a persistent epithelial defect like that in this lady with an agricultural background. Scraping showed acanthamoeba cyst, and you can see that there is peripherally a healing edge, and though there was a lot of scarring on healing, the patient did recover some amount of visual acuity. Here you can see SPKs and pseudodendrite-like presentation in a CL user who used tap water to clean his lenses. Here is another patient who was a farmer and who had a ring infiltrate with hypopion, and he needed therapeutic keratoplasty. Microsporidia can be, it could be a epithelial disease, or it could be a stromal disease, or there could be an ICK also in microsporidia. Here you can see raised stuck-on SPKs. Nocardia, you can see peripheral pinhead-shaped dots, which is filamentous beaded bacilli you can see on scraping. Fungal keratitis, traditionally known as dry infiltrates, and here you can see various kinds. Here in a contact lens user, you can see 2 infiltrates with a satellite lesion. Here was another patient who presented like this with a large fungal keratitis. So here you can see a pigmented fungus, curvularia here. Another hyphate edges typically could be mistaken for dendrites. Another case of pigmented fungus. Here you can see this is an iris prolapse, but here there is pigmentation. So fungi can be septate, non-septate. There could be yeast, pigmented fungi. You can see that there can be various kind of presentation with fungal keratitis. So all these, and you can see it in confocal microscopy also, which we will discuss later. The other things that I wanted to show here was, I'll just take a minute extra. This was a patient who had polymicrobial keratitis. So when she did not use her antifungal, the infiltrate actually increased. But when antibacterial, antifungal were used, she scarred. Another case which I had shown earlier, which is the plaque acanthamoeba with fungal keratitis. A third case of nocardia with pseudomonas in a contact lens user. This is important. Here you can see a patient who was treated on antifungal but had broad sparsely septate hyphae, worsened with antifungal, and topical linezolid with azithromycin. She showed improvement, so it was pythium keratitis, where you can see this tentacles, guttering, that is very important to note. And also in a similar patient who was mistaken for fungal keratitis, showed broad aseptate filaments, and it resolved finally. This was another case of pythium keratitis. So another case where there was fungal keratitis, also there was Proteus, he needed therapeutic keratoplasty. Another patient where there was atypical mycobacteria with coagulase negative staphylococcus, and it took at least 8 months to heal.